when Charlie Cook approached me and said, Marion, you're involved in a lot of activities in the Harrisburg community, and would you get one of these for the issues class? And I said, well, my first choice would be the United Way of the Capital Region, because it is such a vital organization to our entire community. And I said, but I don't want to be responsible because we're not sure where we were going to be and what we were doing this summer. And anyway, long story short, Sue reached out and made arrangements with Tim, and I'm thrilled that he's here to present to us today. Bill and I have been involved in the United Way. It goes back so far, it's unbelievable. But there have been so many strategic persons in Jerry Church who have also been so involved. And so we all really do believe in the impact that the community receives from the United Way. And so with that, Tim, I don't even remember how many years you've been head of the United Way, but you'll have to do that. And you'll have to really introduce yourself, other than the fact that we're very happy that you're the CEO of the United Way of the Capital Region.
Thanks, Marion. I always am proud to say Marion was one of my first volunteers. So she taught me a lot when I came to United Way. I started with United Way at what we call in the system in 1991, and then came to United Way, the Capital Region in 96. And then I've been there primarily ever since, a couple years here, there, in and out. But I've been the CEO now for 9 years at United Way, the Capital Region. But when Sue George approached me to speak, she gave me kind of an area, but I wanted to just quickly, this year is our 100-year anniversary at United Way, the Capital Region. So I wanted to touch just a tad bit on how United Ways began, because most people don't know the stories of them. I jokingly say it sounds like a horrible beginning to a joke when you say a woman, a priest, 2 ministers, and a rabbi got together. And that's where United Ways actually started, in Denver, Colorado, more than 125 years ago. And those individuals came together to really say, why are we doing all these separate activities in a community when we could, if we collectively get together, we could do more good as a single entity? And that's really where United Ways began. Our United Way began in 1921. We were called the Harrisburg Welfare Federation, was the name of our United Way. But there's lots of names that I think people maybe not be familiar with United Ways, but we are all these things, and we're all called United Way now. But we started as welfare federations, we started as red feathers, we started as community chests. So I always joke that everybody's been involved with the United Way if you've ever played Monopoly, because when you pull that little card and win your $10 prize for the second prize for a beauty contest, that's the United Way in Atlantic City. Actually, it's all based on that area. But United Ways adopted the name and really centralized their work over the years. Around the 60s is the time frame when you started hearing the name United Ways, and now we are all United Ways, and we are collectively put together the largest charitable organization in the world by revenue. There's over 1,800 United Ways in 40 countries, and revenue-wise, raising over $5 billion on an annual basis in the community. And United Ways are all autonomous, so we're not set up like a Red Cross or a Cancer Society where they're top-down driven. Every United Way is driven by its community, has a local board of directors. Now, with that said, though, we share the name. There is a United Way worldwide. We have to meet stringent criteria to use that name. We work together to solve multi-community problems in those areas, but we are all locally driven. So I always say one of the great things about United Way is every United Way is local. One of the bad things about United Way is every United Way is local. So it's for us to really move the needle on significant issues, we have to really come together as separate entities and really work on similar issues in those communities. In Pennsylvania alone, there's about 53 United Ways. Our United Way covers Dauphin, Cumberland, and Perry counties, those areas. But there's a United Way in York County, there's one in Lebanon County, there's one in Lancaster County, Mifflin, Juniata. So we're surrounded by other communities with United Ways in them too. Our United Way really, and what I think most people are familiar with United Ways, especially in the workplace, was the fundraising efforts, the annual fundraising time. I always say that term I gave at the office is, well, you're talking about United Way when you say that, because we were Other than taxes, we were the first payroll deductions to ever begin. But what you can't say is when you say the word United Way, it's not a single word that describes us. You can't say the word children. You can't say the word cancer. You can't say, because United Ways and what makes them unique in all their communities is they try to make that community better for all their citizens and residents. And that might look different in every community. So United Way transforms itself over and over and over and over based on community needs. And United Ways have gone through that transition for many, many years. Our United Way went through a similar transition just about 8-9 years ago. We did a significant community needs assessment of the community and said, how can we be most relevant and solve and work on solving the greatest issues of our community? Prior to 9 years ago, the product that we offered, what we did community-wise, which was very effective, was we basically vetted charities on behalf of the donor. We would look at charities, they would come to us and service organizations and say, this is what we do, this is what we do very well. And we had volunteer panels, allocation panels that would look at those charities and they would hold them accountable to that, and we'd raise dollars for those charities. What we found through our assessment, and our assessment was significant. We looked at 82 indicators in the community, everything from poverty rates to educational attainment to health rates to housing to you name it. We looked at those and said, how's our communities doing? And our community again was Dauphin, Cumberland, Perry counties we looked at. And then we said, where is needs greatest? We then sent out a survey. Over 16,000 surveys were sent out to the community for what people felt were the most important issues. And then we held community conversations where we took the data and we took the opinions of people and put them together, especially where there were differences, and held conversations throughout the communities. And we held these in everywhere, in Newport and Perry County, out in Hershey. We held them over in the West Shore, downtown Harrisburg. And this is really what drove us to look at how we could change the organization and to address those greatest needs and the ones that weren't being met at that time. So we went from an organization that vetted organizations where they came to us and told us what the issues were, to us identifying the issues and finding the organizations that could best meet those issues and do it collectively together. Now, if you ever get bored, you can go out on your computer or on your phone or your iPad or anybody like that and Google the word collective impact. This is a model that we really adopted. And the idea behind this collective impact model was that people have multiple issues. It's not a single issue that has put them in where they need. So I use an example of a child's not performing well academically. A single after school program most likely is not going to help that child. There have to be family supports along the way to continue their education. There might be health issues. There might be other areas that are causing why that child's not doing well. So the collective idea is, let's look at all of those potential issues and pull together the support systems that exist in our community and the entities to try to make sure that child can succeed. So it's not just the after school program, which is vitally important, but what are those other needs that exist for that child? And this is really what the collective model was. In United Way, we're very fortunate. We have community leaders, a very strong base of community leaders that support us, from corporate to community organizations, to government, to ministeriums and religious leaders that have supported us for years. So we had that ability to bring folks together around issues. And this is really the model we've adopted collectively to try to solve those most pressing issues. Now, we knew we couldn't do everything for everybody. I used to always say when I worked at United Way 15 years ago, we did everything from birth to death. And we truly did. We funded the first baby drop-off program. So if a mother didn't want their child, that there was a safe place to drop that child with no questions asked. The whole way to families that could not afford funerals, a program called Compassionate Closures, which still exists today, so that a family could have a proper funeral, and we did everything in between. So we did a little of everything in the organizations we supported. But what we also found through our assessment, though, is that based on our mission was to try to lift the community up, we also found that we could not say that we were moving the needle on any significant issues in the community at a community-wide level. And the question we asked ourselves was, could we do this? Could we improve something at a community-wide level? And this is where we decided to narrow our focus. So we looked at the four kind of big block areas. We looked at income, we looked at health, we looked at education, and we looked at basic needs, and said within those areas, are there ways that we can move the needle, change the condition of our community for the better on significant issues at a community-wide level? So what we did is we used the assessment information, we used the community input, and then we brought experts together in each of those areas to study best practices in other communities, to understand what our community could and use their expertise. And where we really narrowed our focus was in the area of education. Where we ended up was on school readiness. We looked at high school programs, we looked at middle school programs, even later elementary school programs, but where we found the greatest need, where there was the least resources, was getting kids ready for school and making sure there was a level playing field in those first years of school. Because what we found out through our data is that's where we put the least amount of money and have the least amount of resources that are available. But those are the most formidable years of a child. By third grade, if a child is not reading at grade level, they're 4 times less likely to graduate. That's a number that just blows my mind. I'll say that again. By third grade, if a child is not reading at grade level, they are 4 times less likely to graduate than their peers are. So we knew that this was a vitally important area. And it wasn't just us saying this. This was driven by the superintendents from the schools, the Department of Education, child care centers, educators. They're the ones that drove us in that direction. So in the area of education, we decided to really focus on getting kids ready for school and succeeding in those first years. In the areas of health, we looked at all these different indicators. We looked at everything from diabetes to obesity rates to heart disease to other areas. And where we did was took a step back and said, we can work on all of those issues if we get people access to what we call a family physician, a medical home. Because when you have a medical home, it's not just about getting and solving an immediate need. It's also preventive care, as we know, it's specialty services, it's other areas that can address those. So, and we knew by getting families, because so many families did not have a medical home, they were using the emergency rooms as their primary care areas. And we know in an emergency room, as they solve a single issue, they aren't looking for preventive and specialty areas. So really where we decided to focus in the area of health was really working with low income families to get them that medical home. Interestingly enough, in the area of income, we thought we would be focusing on housing, but where the community drove us to and the data showed, it was workforce development. And we kind of shook our heads at United Way and said, oh, United Way doesn't do workforce development. That's the chamber's responsibilities. That's business's responsibility. But once we understood more about workforce development, is we understood there were good jobs that were available. We had very good training programs that were available. We could identify the unemployed and the underemployed. But the question was, we couldn't get them in the right positions and they couldn't keep those jobs. And the reason was, and this is where United Way came in, is because they had barriers that prevented them from keeping those jobs. Things that are common to United Way: childcare, transportation issues, what we call soft skills, the idea of what it means to show up, financial literacy, that how do you spend money once you get it? And this is where United Way fit in. So we started to understand how we could be involved with workforce development, because we know once a person has a living wage job, a job in which they can pay their bills and do well, they see many less issues in the areas of education and health and basic needs in those areas. So there's a direct correlation between somebody's and a family's income and what their needs are in the community. And last but not least, in the basic needs area, this was an area where the community told us loud and clear, we need you, United Way, to fill gaps in services, those holes that don't exist in food, clothing, and shelter, to make sure that if somebody loses housing or needs it, that it exists immediately, to make sure that there are behavioral health services that exist for individuals, to make sure that if we have a disaster or a community issue, that you can do that, to make sure that food distribution gets to where it's needed and distributed well. So this is an area that we did well, and we decided to really stay in those areas. So these became our focus areas: getting kids ready for school, getting people access to those medical homes and to work in that area, to make sure that for workforce development that people could get jobs and keep their jobs. And in the areas of basic needs is that food, clothing, shelter, where people had immediate needs. Now, what we had to do to make sure we were relevant, though, was to say it wasn't just about providing somebody a service. It was, could we measure and make sure they succeeded in those areas? The kids that were entering kindergarten and getting ready and for first and second and third grade, would they academically do better? Not just the number of kids that were in the program. In our world, we call this outcomes. Outputs or counts. They're important to know how many people are participating in a program, how many people are served, but are we actually changing their life? When it came to health, once somebody had a medical home, are we actually improving their health? Are they managing their diabetes? Are we lowering obesity rates? Are we heart disease dropping in those areas? When we talk about the workforce development, it's not just finding somebody a job, it's keeping that job. Are we improving their retention rates? Do they, after a year, still have that job? Are they moving in that direction to earn that living wage? So this is really what we challenged ourselves in this collective model, was to say, it can't be just about the number of people in these programs, but we had to show success. We had to get, in the for-profit world, results and show those areas. So that was the challenging of the programs that we did. So this is where really over the really first 4 years from 9 years ago, we spent was putting this programming together and then transitioning from that model of what we call that allocation, of that funder allocator model of the agencies telling us what they were doing and us vetting them, to us identifying those needs and pulling together the service provision in the community collectively around the table. What was key to this process was getting the right people around the table. We knew we couldn't succeed in health unless the hospitals were at the table. Penn State Health, UPMC Pinnacle. We knew we couldn't do without the insurers with Highmark, Capital Blue Cross, Gateway. We knew we couldn't do without the free clinics. We knew we couldn't do it without the county assistance offices. So all these folks are brought to the table to work together on these issues. In education, we knew we needed the superintendents, the principals, and the kindergarten teachers. We needed the Department of Education. We needed the child care centers at the table that were experts in those areas. When we looked at the workforce development efforts, we knew we needed the business leaders at the table and had to do it through their eyes. We had to have the good training areas like HAC and other ones that provided training facilities and the case management services that could do that, and the employer driving the process to be able to do that. So this is where that collective model came into play. This is where we invited folks to the table to be part of this. I'd like to tell you everybody came to the table to hold hands and solve these issues together. But and it doesn't quite work that way, as we all know. They all have to have self-interest, all right? So we knew that Penn State and UPMC wanted to be at the table because they didn't want uninsured individuals using their emergency rooms, because that drives their healthcare costs up. So if we could provide people a medical home or get them insured, now we have paying people that can do that. We knew the health insurers wanted to be at the table because they want people on their health rolls, paying people on their health rolls, and that benefits them. We knew the free clinics wanted to be at the table because we gave them money to be at the table, to improve their services in the community, to be able to do that. In the cases of education, we knew the schools, which have been traditionally hard to get involved with communities, well, we basically gave them a staff person is what we did, a free staff person to work out of their schools. They're not going to turn that down, all right? So we knew there had to be reasons for people to be at those tables. So part of the collective model is, it's that old 80s term, what's the win-win in it for everybody? We want the community win, but how do we get those entities to work together? What's the win in it for them? So we went in with eyes wide open, knowing that to get those partners around the table, we had to provide that. We also needed excellent leadership. So here's my shout out to the Alexanders, for example. We knew we had to get a well-recognized individual to lead our workforce efforts. So we, on a soft moment, we plied Bill Alexander with food, and we said to Bill, would you lead our workforce effort to do that? And in a soft moment, which he probably regrets, he said, sure, Tim, I'll help you out. So to do that. But we had to get those really good community leaders around the table to really add not just the United Way name of legitimacy to it, but to add their support and behind the scenes. So we were very effective. We got Phil Garnaschelli from UPMC, it was Pinnacle at that time, to be at that table to help with the health effort to be able to do that. We made sure we actually got the superintendents from the schools around the table to be part of those and had people collect those for us at the table. We got David Volkman, who was the Assistant Secretary of the Education, to help lead that effort for us to be able to do that. So we knew that was vitally important. So with these efforts, we have built these all along in each of those areas, knowing that every single one had to drive towards an outcome. They all had to make sure that they got results in building these efforts. And what we were fortunate about is United Way, we had the resources to make that transition and also introduce this model at the same time. And then we knew this would take time. The great news is after about 3 years, these programs now are getting results. And this is what's really exciting about this work. And this tells you if you put really smart people around the table, if you really use this collective model, you can succeed and actually get results, not just outputs. You can get outcomes, not this. So in the area of health, for example, we employed a model, what we call a health worker model. What we found was we had significant and robust resources in the community with a few gaps that existed. But the question was, why weren't people accessing those resources? Well, we found out there were several reasons, and they were different based on the community. In Harrisburg, for example, very, very robust services, but the people didn't trust a doctor would help them. They didn't know what services existed to them. They had transportation issues on not for themselves, but if they had a child, where do I put my child when I go to an appointment? In Perry County, they trusted the services, but no transportation because most of the services existed either in Cumberland County or Dauphin County. So they couldn't get to and from those areas to receive health services to be able to do that. So these are the kind of things we had to look at in each community of why. And the model we came up with is what we called a health worker model. We hired individuals and trained them from each of those communities to connect with individuals, low-income families in those communities, and say, let's kind of do an assessment of you and see what you need so we can get you health services. So we worked with health navigators to get people insured. So we were successful to date of getting over 600 people now insured that were considered uninsurable, just because how the system works and how complicated it is. I sit there with my mom sometimes, and my mom's on Medicare and her supplement, and my mom's a registered nurse, and we have to sit there and try to figure out that health plan together, and she's used to looking at those. So for those that are even well-educated and that have good incomes, it's difficult to understand our health systems alone, and you might have experienced that. So can you imagine being a low-income family with 1,000 things going on, 2 jobs going on, and trying to figure out how to access a health system? So we help families that didn't think they could get insurance. Their children get CHIP. They might be eligible for Medicaid. They might be eligible for Medicare. Many of these families found that they didn't think it was affordable for them to even pay for health insurance. And they are on and through the exchange and other programs, they actually have health insurance now, but let's get folks insured that were considered uninsurable. Then let's find them a medical home. What are the barriers of why they don't have that family doctor? Is it because they don't have childcare for their child to go see it? They don't trust that family doctor. They're unaware of what exists in their area. And this is really the jobs of those health workers, is to connect with those families and help walk through those systems. The thing that I want to share with you on all of this programming, though, is I call this opt-in programming. We only provide this programming to people that are interested in improving their lives. For years, we spent trying doing programming that was just offered to everybody. And would they take advantage of and trying to convince them to use it? In our cases, you have to opt into this programming, the recipients. I want to improve my health. I want to get a job and I want to keep a job. I want my children to do better in school. And this is one of the reasons our success rates are so high, because the folks that come into this programming, the secret that most people don't understand about this is most people want to improve their lives. And they're willing to do that. They just don't know how. So this is where we work with these individuals, these health workers, to help connect people to these services. Well, the good news is over 600 people insured in the first 2 years that were considered uninsurable. Over 887 people now have a medical home that didn't before. So they have that family physician to be able to do that. And we're now starting to track those that have that family physician, that medical home, those health indicators to say, are they doing better? We've reduced with those families, those 887, we've reduced emergency room use by 60%, where they are no longer going to the emergency room, but instead using their family physician. And that saves all of us money. And it also gets them better service to be able to do that. We're going to continue to monitor those health indicators. And if you ask me back in 2 or 3 years, I'll give you updates on how they're doing on diabetes management. Are we reducing obesity rates? Are we looking at these key health indicators and how those families are doing? The good news is we're already starting to see good health indicators, so we know this model is working. We also know this model, this health worker model, is working so well that we've now seen an explosion of health workers in our community now. We were kind of the only game in town around this. And we have some in Harrisburg, Cumberland County, some up in Perry County. So we were kind of that. Now we've seen this explosion where they're being paid for by health insurance company. The health system themselves are outing. So we know this model is starting to work. And that's always been our goal, is to create models that work and that work very well to be able to do this. So we're very excited about our health program, that Contact to Care program. The numbers are there. You know, we connect people to services. If they need food services, we connect them. So we're really working as a case management service as health workers do that. We move on to school. What's fascinating, the school individuals got together and they came up, unknowing that the health workers did, they came up with the exact same system. They just call them health liaisons, is what they call them. Or I'm sorry, education liaisons is what they call them. So we had health workers, but in education, they came up with this idea of education liaisons. The idea was, let's work with families beginning at the age of 3 that have 3-year-olds, and let's help them connect to services in their community to level the playing field. So when they get to kindergarten, they have just as much opportunity, and our kindergarten teachers are teachers and not social workers. That was really the idea about this. So what we did was we went through the Capital Area Intermediate Unit, and we said, if we provide you money, could you hire education liaisons for schools that could work through the schools with the families in those elementary schools of low-income families? Well, we started with 3 school districts. We're now in 9 school districts. Overall, we have over 17 elementary schools we're working in. But really what happens is the education liaisons connect with families and they do an assessment of the family. If intervention is needed on health issues, they automatically get connected to the Capital Area Intermediate Unit in case there's any issues that the family might not have been aware of. If the family wants to send a child to a quality child care center, we work with multiple child care centers in the community where there are dollars available to help them pay for childcare. And if they want quality childcare, we know it works very well, and we'll connect them to those positions and get those kids in childcare. If there are no intervention issues needed, if there's no want for childcare, they want that, we provide workshops out of the schools and also out in the communities for the parents to bring those children, or the family unit, whatever it looks like, to bring those children to these workshops. The secret about this effort is we provide educational methods for the child to learn, but more than anything is we're teaching those parents or those individuals how to support their children through education. They have to be part of the program. Again, this is opt-in. You can't just drop your child off. You have to have somebody there with that child. And at the same time, we're helping these families learn and teach them on how to support their child, not just to get ready for school, but how to support them as good individuals and family members throughout their educational career. So we start with 3-year-olds, 4-year-olds, 5-year-olds, the whole way through up to 6-year-olds into kindergarten. And then we continue to provide those supports the whole way through 3rd grade with these children. So the other program we look at where there's communities is Head Start. So if Head Start exists in that community, we also might connect family members to that, because Head Start is very successful to do that. These workshops, we have had over 13,000 kids participate and family members participate in these workshops. The good news about this is we already have the educational attainment rates now for kindergarten and 1st grade. And the kids that are part of our program either have been placed at a quality childcare or are going to our workshops, or we place them in Head Start, are academically doing better than their peers. So we measure. The other thing that's interesting about our educational system is each school has its own measurements up until 3rd grade. So it's kind of the Wild West. The school determines what's best for them. We've gotten all the schools to agree on kind of standards of what educational attainment should look like at kindergarten or 1st grade to 2nd grade up to 3rd grade to be able to do this. So for a school to be part of this effort, they have to agree on certain standards. Everybody's like, how do you get the schools to agree, Tim? Well, the thing we found out is that Harrisburg didn't want to have its kids compared to Cumberland Valley, all right? They wanted to compare them against their own kids. So that's what we agreed to. So they look at all the same standards, but they're comparing their kids against their peers, the kids that are in that school district, to do that, which we were completely fine with and had no issues with that. So they agreed to what these standards were. They just used it to compare against their own kids. The good news is our 1st group that went through that's now second graders, and we're getting the data for second grade. But in first grade, 56% of the kids that were part of our program were considered proficient in first grade versus their peers, which was at 47%. Doesn't sound like a great gap, but for a program that's only been around for about 3 years and understanding how that works, these kids are doing better than their peers. In kindergarten, our kids were 66% proficient versus 61% for those kids that weren't part of the program. So we're starting to see improvement. And we're going to continue to tweak this programming to really show that. But if you take a whole kindergarten class of maybe 300 kids, for example, in Mechanicsburg, and out of those kids, if about 30% of them are participating in our programming, these are not small numbers. These are groups of kids. These are 40, 50 kids that are now academically doing better than their peers are and showing improvement in those areas. And this isn't just for a single grade, this is for lifetime. So because we know as these kids, their education just adds to itself, and if they fall behind, it becomes a greater and greater issue. So the good news about this programming is it's starting to show progress. And the great part about this programming is we're going to continue to tweak it to improve those results in those areas. I would love to come back to you in 2 years and show you the PSSA's results, because that'll be the first standardized test that all our kids have to take in third grade. And that will be our ultimate measure. Do these kids do better on this first standardized test than their peers do that have gone through our program? I can't say I'm a fan of standardized tests at all, but they do show that kids that do better on the PSSA's are more likely to graduate, and they do better. So it is an indicator of how a child does in those areas. So this is really what we're working towards. I'm going to take a pause for a moment and talk a little bit about workforce development. But as you can see, I'm passionate about this, love this stuff. But do you guys have questions at all? Like, kind of throwing a lot at you on history. But as you can see, the modeling we're doing is really about case management. It's saying, let's get families connected to the services that exist out there already and make sure that we remove those barriers to getting connected to those services. Transportation, trust, knowledge of them, access to those services. And this is really what we're seeing in health and education so far. Any questions at all, or I'll just love talking about this stuff.
Do you work with any of the free clinics?
We do. So the part about this collective model, Jack, was that let's take advantage of the services that already exist out there. We didn't want to create a single new service. And what our assessment showed us, that there were many areas that we were robust in services in our community. So in the areas of health, the free clinics do a very good job. So we work with all of the free clinics in the Harrisburg area, every single one of them. And how we worked with them, again, this wasn't an educational item. This was actually, we provided them dollars to provide expanded services to be able to accept more. Now, in return, we've asked them to accept the clients we push in their direction, and then also to track their health results and indicators in those areas. So to receive those dollars, they had to be able to provide those services and be able to do that. So ones that you're familiar with, Community Checkup Center, those groups, these are the kinds that we work with. So, and as far as we know, we are working with all the ones that exist in the Harrisburg area right now. So.
And one further question, a little different. I'm used to giving money like on a payroll deduction in the past to United Way. Is there a way to direct any contributions from an individual to a particular area through United Way?
Absolutely.
Say I wanted to go to education,
yep,
or something like that.
Yeah, so we usually, if you still get, it's interesting now, about 60% of our donors now give electronically, all right? But if you're still fortunate enough to get one of those pledge cards, which we argue about every year what it'll look like, but you'll actually see on the card, you can make the general gift to United Way, which gets divided among each of these areas where need is needed. But also, if you're passionate about one of these areas, you can absolutely direct it to one of those areas. The school readiness effort, you can direct it to the access to health effort, the workforce development, or the basic needs area. We all still serve in that role of being a community fundraiser. So, and we take that role very seriously, which is United Way's always served us. So people can direct gifts to any organization, any legal organization they so choose to do through United Way too. So if you want to support your local SPCA or fire company or another organization, we also raise money on behalf of the community. So as a donor, you have that choice, the general gift to United Way. You can pick one of these initiative areas if you're interested in, or direct to a single organization too.
I have a couple questions for you. One of the things, since I've retired, whereas I always gave to United Way when I was employed, you've kind of become invisible to me. And I think that probably happens to everyone who retires. So whereas I was a consistent giver when I was employed, I've totally dropped off your radar screen. I mean, other than people who invite you in like we did, partially for this reason, how do you reach the senior market, if you will?
Yeah, and I'll tell you, I am the greatest fan of United Way, but also our greatest critic. Okay, too. So and I say we're horrible at keeping contact with folks once they leave the business place. So what we've tried to do though is we ask for information that you give us. So if people are willing to give us that home address, if they're willing to give us the home email versus their work email, we have recently become much better as we find out they leave the employer. Now, the employer usually doesn't let us know until a full year has passed. So we lose a year in there because that's our connection in many ways. So one of the downsides of United Way is we're dependent upon the employer to go through them for our connection to the employee in many cases. So we're really trying to develop individual and personal relationships where people will share information for us, they're personal. And that way we've started to do a better job of connecting with them. So once somebody gives us that information, then if we notice they're no longer in that employment ranks, we go, oh, let's reach out to this individual and try to get them involved with us then and re-engage them to do that. So we are just starting to do a better job with that. But also you can direct people, or anybody can go to our website and they can give online. They can let us know they'd like to receive information to do that. But again, is that top of mind for you when you're thinking of that? So we're trying to do a better job when we have individual information, but brutally honest, we did a horrible job in the past around those areas. We are doing better now where we have personal information and trying to engage independently with people, not through their employer, to do that. So I would say in the last couple of years, we've done a much better job with that. But anything prior to that, I would say it's unfortunate, but we just went through primarily employer side of it. So we're trying to do much better on that now.
Yeah, my second question really kind of relates in the sense that as what you were discussing here is your ability to reach us, to tell us how we can help. The other part is, how do you reach the people in need of the services? I mean, you have a huge number of services that you provide and you help support, but getting the attention of the people who need those services I don't know how that happens.
Yeah, and that's an excellent question. So, and I kind of skipped over that, and I apologize for doing that. Part of that health workers model, part of that education liaisons, part of the case managers work on the workforce side, which we can chat about in a little bit, is also community outreach. So the health workers, for example, part of their job is, let's use ones that we have in Harrisburg. They will have appointments where they go sit at the Latino Center for every Thursday morning for individuals that walk through there. They go to ministerium and churches where they engage in those community activities, truly where they're civic centers to do that. Emergency rooms in the hospitals are given information about if they see somebody that's uninsured, that they'll refer them to us to be able to do that. So far we have had no issue whatsoever of a number of individuals and actually it's pushed our capacity in the program that's growing. In education, we go through family members. We do literally in Mechanicsburg, they walk door to door in the lower income communities and they'll knock on the door and hand a flyer of saying, hey, this is available and these services are for you to do that. In the case of our workforce development, our case managers are at the Salvation Army, they're at New Hope Ministries, they're at Goodwill, they're at Tri-County OIC, they work out of those areas so that as individuals come through on other needs, they might have food needs or health needs, they also, part of their assessment is, can we work with you in the workforce development area? So part of each of these roles is also the marketing of these efforts. There's also one other way, and this is available to all of you. You can pick up the phone right now and dial 211, not 911, but 211. most people are unaware that this exists, and this exists nationwide. Any individual in the community, if they need non-emergency help, i.e. I have a fire at the moment, or suffering a life-threatening medical issue, can dial 211, and we work with Contact Helpline. We pay for this service through them and use them as a vendor, that they will connect any individual to any service that's available in the community that they're aware of that exists, also referring them to our program too. So last year alone, they did over 57,000 calls for us of connecting individuals in our community to services. And those include these initiatives too. So if you have a family member, you yourself, a friend, a neighbor that's in need of behavioral health services, rent assistance, they don't know where to turn to receive a service, they can dial 211. You can do it from your cell phone, your landline. There's also a way you can text and stuff too to be able to do it. So you can do that, and they will connect that individual to those services where they have somebody, if the service exists, that can help them to be able to do that. So our health workers, our education liaisons, our case managers and workforce development, 211, these are all outreach efforts. But in addition to that, I'm talking to you today. We probably do 400 meetings a year, 500 meetings a year of just educating the community about services that are available to folks too. So word of mouth is another way to do that too. So those are our outreach efforts. The good news is we have a lot of folks out there reaching out. The bad news is, to your point, we're probably only touching, I don't know, 20, 30% of the population. So there's another 70% we want folks to share this information with and get it out there as much as we possibly can. So.
I'm interested in your early childhood development. How do you, I found from my experience, getting the child educated is only one step. It's having the family members involved to ensure that they stay on track. Is that part of your education liaison person?
It is. So the workshops they hold we actually divide them almost in two groups. And the activities we create with them is we help teach those family members of how to engage with that child and support them. So often, the kindergarten teachers themselves, the education liaisons will do the activity. So for example, just last week, we were over in Cumberland Valley. I forget the elementary school's name, but we were doing the kids loved it. It was a bike program. So a couple of the local organizations that provide free bikes were there or parents could bring their kids' bikes to it. So the kids were out riding all these little courses on the playground and stuff and having a blast. At the same time, though, we were teaching the family members, the parents, the uncles, the aunts about bike safety. We take that for granted. We say, oh, I taught my kid. They know to stop at a stop sign, look both ways. They know to look at the bike before they send the kid out on it to make sure it's safe. And we actually have folks individual there working with the families to say, this is what you should look like for your child. You're responsible for teaching your child. And then we unleash the parents then to work with the child on their bike to be able to do that. And that's just an example of I will call it a life education, not necessarily, but we do the exact same thing with every kid that's part of it. Part of the agreement the parent or the family signs with us is a family member, hopefully it's the parent or an individual that works with them, will be at every one of those workshops with the child. You can't just drop the child and go. And we have a family engagement effort that exists. So we might work with the child independently, talk to the parent, and then put them together at each one of these workshops on how they can support that child. But the amazing part that I've seen about it is that once that parent becomes more comfortable, they'll start automatically engaging with that child, or they'll let us know what their needs are. I don't speak English well, so we can get them an ESL class and understand how to English as a second language. And so we can support their skills at the same time to be a better parent, to help them be more supportive of their child. This is how the American education, so many of the kids that are part of this program really are, their language barriers, there's education barriers, there's things of that nature that exist. And we work on those in addition to just helping that child to be able to do that. But for a child to be part of the program, the parent has to agree that they're going to be, or a family member has to be there with that child at everything that we do. So. Well, I can wrap it up for you. I'll do this because I can see the Alexanders, but Bill's helping us lead a workforce development effort. And this one's kind of amazing for us. Okay. So again, I didn't think this is an area we would be in, but what an incredible need. We know the ultimate solution is a family that has an income where they can start and have that ability to be able to pay for services. And the goal is what we call self-sufficiency, is to have every family that we work with, that they no longer need subsidies. They're no longer just living paycheck to paycheck, but they're starting to save for other areas, a home, a child's education, that they aren't just living from a day-to-day aspect. And this is really where the workforce effort works for us. Again, I mentioned before, we have great employers. And right now we're working with 24 employers in our community. We have great training programs from groups like HACK and the community services areas that work in these. We work with what's called the WIB, or Career Link, as often is referred to, that identifies individuals that are and underemployed for us. And what we do is we work with them, very similar in the education and health efforts, is we work with the individual to assess what type of work do you want to do. You know, for the longest time, we studied failed programs. Let's use truck drivers, for example. You know, everybody heard there's a great income. You can make $70,000, $80,000 a year to be able to do that. They would go get their the CDL license. They would get behind the wheel of a truck, and 2 weeks later they would quit. All right, so didn't work for anybody. A lot of education, a lot of time spent. Well, because there wasn't good assessment done with the individual, would they like that kind of work? Would they be willing to do that kind of work? Because it takes a certain individual to do that. So this is part of the assessment. We work with the individual of what their wants and needs are. You know, there's a lot of medical assistance jobs out there that an individual can get and then move on to be an RN or an LPN. But a medical assistant, we know they're changing bedpans, they're helping individuals, they're doing these kind of areas. It takes the right kind of person to be able to do that. So part of our program was to work with individuals to say, what do you desire? What do you need? And let's get you proper training. And then let's work with this. A case manager works with them and place them in a position and stay with that individual through their first year of employment. They're going to call them on Sunday night to say, hey, you're going to work tomorrow on Monday morning, correct? Oh, you have a child. We have a backup plan for that child. If your childcare falls through with Aunt Susie down the street, what's our backup plan for your child so that you can still go to work? What are we going to do for transportation to get you to and from work? This is really the things we're working for in our workforce development efforts, and understanding those individuals, what their needs are, and then basically teaching and helping them understand what it means to be a good employee and to make sure things that we take for granted. I have a backup plan. I know what I can do if my car needs a repair. You know, what if I miss the bus or something of that nature? What can I do otherwise that I make that call to be able to do that? This is really where we started. We only work with employers. We sign a contract with them that have a path forward. Many of the positions we fill are entry-level positions. They're not living wage positions, but there's a path forward for that individual then to ultimately go to that living wage. So as I mentioned, like the UPMC Pinnacle, many of the individuals we bring in are medical assistants. A medical assistant's not a living wage position. Somebody cannot survive on that alone, but there's opportunities at UPMC for them to move, to get education, free education along the way, to become an RN or an LPN. We know that at giant food stores, we'll place somebody who stocks shelves or something, but there's a path forward to become a department manager or an assistant manager of the store, or to move on to corporate headquarters. And they have that path that exists forward. So we will not sign a contract with an employer unless they have a progressive path forward and show a way for that employee to move forward if the employee so desires. And we work with them to do that and provide those case management services. There are certain employers we haven't worked with. They're great employers, but for example, Amazon is a great warehouse out in Carlisle, but Amazon doesn't have a path forward. The folks they hire, they want them to be package handlers on those lines, and that's where they stay. So we don't work with, and not that we have any issues with those businesses, but those are not the businesses we work with. We only work with businesses where they have a path forward where somebody can earn that. But the services we're providing are to make sure that that person has the right training, it's the right fit, and that they can show up to work every day and that their needs are being taken care of. If they don't have health insurance and they don't get it at the employer for the first 3 months, we'll make sure that person has health insurance so they have no health issues for those first 3 months. If they're need transportation, we will make sure they have transportation until they can afford, with budgeting and financial help, to get that first car. Because in central Pennsylvania, you have to have a car to be able to transport. We just do not have enough public transportation to exist to be able to do that. And we have a car purchase program now that we have started where the individual buys the car and we work with them on budgeting and how to be able to do that. Childcare, we help them with their childcare until they can afford to start paying for that childcare themselves. Soft skills, we make sure they have plans and understand what it means to show up every day, how to be an effective employee, to make sure they understand to have those plans in each of those areas. The good news about our program so far is the folks that we placed and the employers that we work with, we have a little over 70% retention rate for the folks we placed. At those same employers, their retention rates are 55% when they hire somebody off the street. Think about the costs we're saving that employer on retraining people, constantly hiring folks by giving them somebody that stays there. And we provide these case management services through the first whole year of employment for these folks. If it takes a little longer, we'll do that. It takes a little less time. But so far in a program that's only existed for 2 years, we have now officially graduated 36 people that are completely self-sufficient now. Doesn't sound like a lot, but it's a great start. These are 36 individuals now that are self-sufficient. They can pay their bills and they're saving now. This number is going to multiply significantly over the years coming up. So we're going to turn that number to 150 to 200 to 400 to 500 individuals over the next 5 to 6 years to be able to do that. These are individuals now that have a life and they're teaching their children what it means to be successful too. So this is our workforce program. We don't provide the job. We don't provide the training. We don't identify those. We fill in those gaps and we provide those case management services so that individual can succeed. And we do it at a very, very affordable level for that individual to do that at. So this is all about helping people become self-sufficient in those areas. As again, the case manager is the key to it. So the case manager, the health worker, the education liaison, they all three of them have similar jobs. We just call them similar things. They're helping connect families to services and help them remove those barriers to be able to succeed in each of those areas. So it's exciting. I love this work that we're doing, and we have some really smart people help put us together on this. So, but this is our new United Way. We'll call it for right.
We have about 5 more minutes. Anybody else? I'll give you one more, Tim. How has COVID affected your operation?
So this is where I had a gentleman by the name of Will Papa. Will is just retired from the Hershey company, but he's a senior executive, ran all their R&D, and he was my board chair. And he said, Tim, nobody will give to you because you're 100 years old. He said, what's most important is, what does 100 years get you as an organization? Well, COVID's a great example in what we did around the pandemic. Because of our relationships that we've had over this time frame, we were able to leverage resources. We didn't go out and ask for a single additional dollar. We raised an additional $360,000 ourselves, and then combined with TFEC, the Foundation for Enhancing Communities, an additional $300,000 just to fill gaps in services. PPEs, masks for organizations, cleaning supplies for individuals, for things of that nature to be able to make sure that charities could stay open. But more importantly, those additional dollars was we were able to connect services. So for example, childcare centers closed at the beginning of the pandemic. They did not realize they could stay open for certain audiences, for those essential workers. So we helped educate them that they could stay with and help them fill out the paperwork to do it. The health workers didn't know that childcare existed, so we worked with Penn State Health and we worked with UPMC Pinnacle at the time to say, hey, these services and these centers exist. These are available for those children to be able to use those areas. So these are the kind of things where our knowledge and working with these partners in different areas allows us to fill in during those times to be able to provide those services. We met with the superintendents from the 9 school districts that we're currently working with in those areas and said, where's your greatest need? Again, it was about support for those kids that they couldn't provide in the virtual world. They were virtual at times, they weren't. So we helped work with communities, classrooms, we helped work with other groups. We provided supplies, materials, and tutors where kids could go to get academic support because they were not allowed to go back in the schools and actually create those areas. So this is the kind of things we did during the pandemic. What we're working on now, we call post-pandemic, is really looking about those government dollars that are available, and as they disappear in the areas of rent assistance and helping for individuals for unemployment, is what's that mean and where are those greatest services going to be needed to make sure we can connect those individuals as they come off. They have to pay for their rent. They have to make sure they get that job. They have to make sure that these food services aren't available to them anymore. Where can we connect them and make sure they understand where those services are and understand what's available to them and not needed to them when these government programs, which are ending, they are slowly ending now over this time frame. People always say, oh, Tim, are you advocate for the government program? And we don't advocate for or against these. They were just aware of them and understand the impact they have on folks' lives. Our goal is just to help people and continue to move them forward. So for us, pandemic-wise, it wasn't those additional dollars. Those are vitally important, but it was really those connections of those gaps in services where people didn't know what existed and entities didn't know how to access these services. You know, we learn loud and clear, the schools, they're amazing what they provide our children and the education they do, but boy, they don't know their communities at all. They really don't know the services that are available. And we love working with the schools because we can help connect them and create partnerships that they didn't think even existed before. The schools have always tried to go it alone. Let's do this alone and we'll succeed alone and we'll solve these issues together. And we found now and that they can help develop partnerships in the community that can make them much more successful and allow them to do what they do best, which is educate and not to necessarily provide social services.
So Jack, do you think it's time that we say thanks to Tim for this amazing presentation?
We are right there, yeah, right there time-wise.
And gosh, Tim, you did a good job.
Yeah, I know. It surprises you, Marion, doesn't it?
And Charlie, I'll make sure you have the current information for the United Way to make your donation next year. Don't worry.
and Charlie, I apologize. I already wrote your name down. So it's, this is the fundraiser in me. If somebody mentions something, trust me. So we'll make sure that we get you some material and add you. And you can always opt out. All right. So we will. So.
Well, thanks so much, Tim. This is just a very informative time.
Well, thank you all for your support and what you do in the community. It's we can't do these things alone. It really is that collective model. So the folks that you support, the individuals, the organizations you do, this is all leads up to that same effort of helping people. So thank you for your dedication and what you do. We are huge, huge, huge fans of the ministeriums and the churches and the help they provide in the community. And being educated about it is a great way to start that effort to do that. So thank you for all the work that you do. So it's truly appreciated.
Yes, thank you, Tim.
Thank you very much.
Thank you.
All right, it's very nice to meet you.
Take care, everybody.
Bye.